Okay, so we're live, waiting here on Instagram. So we're live for a live Q&A here. Hope everyone can hear me and see me once you guys start getting on. We'll see how the audio is doing. First time ever going live on YouTube. Pretty excited about that. Should be a lot of fun. Um, Hopefully you guys have some good questions for me. Let's go here onto Instagram. Let me just leave a comment so everyone knows to drop a question. Wish I knew how to pin a question or comment on there. But if you guys have any questions, I see people are starting to log on here on Facebook and on Instagram. If you guys have any questions, drop them below. Wanted to highlight some things that have been new for us. We recently have been selling our new book for clinicians, Rehab to Throw Like a Pro, the clinician's guide, which is going to go through exercises, mobilizations, whole different progressions and assessments for throwing athletes on the clinical side of things. So we work a lot with injured athletes, and we have a lot of clinicians that have been through our continuing education course and other things like that. We wanted to give another resource that can help medical professionals treat throwing athletes. So we'll go through pretty far in depth in that book on assessment, but we leave out a lot of the minutia that kind of takes place and kind of covers up some of the quality information and other texts. But anyway, drop your questions. I see some more people are logging on. Definitely drop any questions you have, and we'll get to them today. We had a few athletes come in today, just a shorter day, working on some biomechanics and doing some evaluations today. But it's kind of some interesting presentations we saw. One athlete had a question about, or actually his mom had a question. He lifts too far in internal rotation and abduction, so he does too much of what people call the inverted W. And there's different things that we can use and different types of cueing that we can use to get that athlete to throw more efficient. And it's always interesting to hear the questions that you get, because coming from parents and athletes, they're often a lot more difficult than the questions we get from therapists and people that have studied biomechanics and things like that. But she kind of asked about, he's learning this. Is it going to be possible for him to change how he moves? And then after he changes it, is it going to be something that he always reverts back to what he used to do? And that's a tough question to answer, because there's a lot of neurological and motor learning principles and theories that are going on, and we have to consider when we think of that question. And kind of my answer summarized would be, yes, it's absolutely possible to change how you throw, even though he's an athlete that's been throwing a long time. He's 17, 18 years old, but it's absolutely possible to change how he throws. You just have to put the athlete in the right environment to make those changes. So that includes putting them in specific positioning, having them throw from those positions, then requiring to do that with more environmental noise. So I'm distracting him potentially with a conversation, or he's thinking about something else, or there's music playing. And then as we move through the progression and we randomize things, and he's being required to do it from that efficient position, things are randomized, he gets more efficient at doing it. Then we add another piece of variability, or we have him move farther into the throw. So now he has to go through that position. So we kind of proved to them that it's absolutely possible that he change it. And then in terms of the permanence, you have to do repetitions the right way for it to become permanent, but you also have to do them in a way that results in less regression. So if you're always doing them in a serial order, there's going to be more regression than if you do them in, say, a randomized order. And the way that I give instructions and the things that I do during the lesson in terms of cueing and feedback kind of can improve that as well. But just the athlete working on it, repetition is going to be huge. Repetition done the right way, and then ultimately to make it permanent, you need to have some amount of randomization and some amount of environmental change or randomization or variation in the environment to make it more permanent. So drop any questions you guys have. Just wanted to give a little spiel there. I thought it might be interesting to some of you. Got a question here. Are you a fan of crossover symmetry? I'm familiar with the band. Just like any other band, it's a tool that you can use, or it might benefit you, it might not. Depends on how you use it. I don't know if they do exercise programs or anything like that, but in terms of the band, it looks like a nice band. I've never seen one. But let's see, I had a question here. I'm new to live on YouTube, so I see someone's on here watching. There we go. Had a question, trying to bring it up. Hey man, what do you think are the best exercises for pitchers to do at the gym? Well, there's a lot of things the pitcher can do at the gym. We have an entire corrective exercise program that's designed to get athletes strong, but get them strong in positions that they need to be strong to be successful in their throw and be successful as a pitcher, as a throwing athlete. You need to not only have strength in your mid-range, but also strength at end range and be able to acquire positions of the throwing motion. So that's kind of what our corrective exercise portion is focused on. Now you have to have a requisite level or a base level of strength to build upon. You need to have some amount of explosive work, and a lot of that can be your throwing. So your explosive work can be you actually doing different throws and being explosive in your throws. And there's a lot of things you can do in terms of med ball exercises, and we put up a couple of videos on plyometrics and med ball exercise that you can do to be explosive. But in terms of gym exercise, we don't do a lot of standard weightlifting exercise. If you watch our YouTube videos, you'll see that not a lot of what we do is your run-of-the-mill weight training exercise, because throwing a ball is specific, and for there to be transfer to throwing a ball, the exercise has to be specific, and it also has to not only look like a throw, but also has to train the muscles to be prepared to accept the loads that occur during a throw and be explosive in the way that you would be in a throw. So you're always working on training mobility, training the strength at end range, and then also being explosive. So I see some more people are logging on. Some people are logging off, some people are logging on. If you're new, drop a comment. I'm happy to answer any questions, and we'll go from there. That's the point of this. I want to answer as many of your guys' questions as possible. We're going to go for about 30 minutes probably, or until my phone dies here. One of my phones dies. So drop any questions in the comments, and I'm happy to answer. But let me think. What else were some comments that we got online? We talked about internal cueing and external cueing a little bit on Twitter, and we had a couple comments back. And the type of cueing used has to do with motor learning and something called reinvestment, which has to do with how much regression there is back to prior or more inefficient movement patterns. So there's primarily two types of cueing, and they are an internal focus, or I'm going to do this movement, or I'm going to use this muscle. And then there's external focus, which is I'm going to accomplish this goal, or I'm focused on this in the environment. So it might be I have to step over this object, or I have to hold this ball here, and for whatever reason, that's much more popular now. And part of that is due to it has been shown in studies to be more effective for reducing the reinvestment or regression, and it's often easier for athletes to grasp what they actually need to do with an external cue. And internal cueing has taken a lot of heat, but it can be used very effectively, in fact, because you can get an athlete to do exactly what you want to do or get them into a more efficient throwing mechanics or a more efficient biomechanical sequence by having them use internal cues and then reinforcing that with a combination of internal and external cues. And sometimes I use 95% external cueing, and sometimes I use 25% external cueing, where I'm having them adapt to the environment and focus externally. But just an interesting topic and an interesting discussion. External cueing, like I said, is going to be better for reducing the regression back to what you used to do. So a lot less of coaches sitting on a bucket and telling athletes, okay, I want you to, do this. I want you to do that. Step to your left now, okay? Or whatever. A lot less of that, more of maybe put an object on the ground so they can't step to the right, and now they have to step more to the left so they don't step across their body. But I got a question here by Dom 10 Mora. Thoughts on Driveline? It seems to be very popular with some of my buddies. It is popular. My thought on it, well, basically, we approach things a little differently. Our approach has more to do with the medical side. I don't know everything what they do over there. I don't. I know a little bit of what they do and what they used to do, but we do not use weighted baseballs. We do a lot with static positioning, asking athletes to contract from different positions in exercises, having them do different types of corrective exercises that I haven't seen anybody doing anything like these. Ed Martell, who founded the OAI, actually put this program together, and it was a lot of thinking on his part, and then subsequent programs like the Advanced Rotator Cuff Complete are the same way. It's been a lot of thinking, and a lot of thinking on the physiology, but also the neurophysiology of how the muscles contract and how the muscles ask to contract during the throw, and then from there putting together exercise prescriptions based on that. And then in terms of the throwing, it's based off of a few things. One, and often the most important but most overlooked thing, is anatomy. You have to understand how the shoulder and elbow and really all the joints articulate, and then from there you have to be able to know where the limits are dynamically when somebody is moving, when somebody's throwing at a high rate of speed. So you have to be able to tell how the joint is moving, say on video. And then from that, you have to be able to design things to get the body in more efficient positions, both mechanically and then also anatomically, so that muscles have the best potential to contract at their maximum force and their maximum contractile speed, and then you're placing less stress on connective tissue, ligaments, tendons, things like that, more based on the congruency of the joint, more based on bony anatomy. So you're subjecting the UCL, the anterior capsule of the shoulder, to less stress, and then maximizing the physics of the throw. It's always the physics of the throw, how fast you can move, which is a combination of both the physics but also how your muscles contract, and then if you're relying on ligaments to hold things together, you're relying more on bony congruency, and you always want to put your joints in the most stable positions. accept load, especially in the throw when there's a ton of valgus stress. So tough question, I guess. Maybe I guess my explanation was tougher, but we have a lot of differences in our approach. Like I said, ours is focused a lot more on the biomechanics of the throw, a lot more on the neurophysiology. That's what we focus on. So I don't really, like I said, I don't know everything they do over there. I can only go based off of what I know of what they do. So I see some new people logging on. Drop any comments, any questions. Happy to answer any questions. We haven't done an Instagram live in a little while, or never done a YouTube live, and we haven't done a Facebook live since we did our last Instagram one. So happy to answer any questions that anyone has on training throwing, whatever. Let's see if I missed anything. Crossover symmetry, I don't know. Maybe someone can drop me some info on the crossover symmetry. I don't know if they have workout programs or what they have. That was one of the questions, crossover symmetry. Don't know much about it, just know that they sell bands, and they look like quality bands, but in the end, it's always the person using the band and how they're using it, especially when you're training throwers. So, thinking about going till about 10:25 or so about 7-8 more minutes based on our time. So if you have any questions, definitely drop them quick, and I'll make sure to get to them. No, I went a little in depth on things, but what's new with us? Baseball season's pretty much winding down here, so guys are starting to head into fall ball and things like that. And if you are going into fall ball, it's important that you work on how you're throwing, because you've just went through an entire season, potentially a high school season or college season, summer season, and now you're going into fall ball for college, or you're just going into a separate fall ball season. And this is when injuries happen a lot of times, because you've just been going from March or February or even December if you're in college all the way through, and now you're going to end up going until late October. And things are going to be getting colder, and especially here where we are, we're in Michigan, so things are going to be getting colder. And if you've been throwing the wrong way, or you've been throwing with some sort of biomechanical fault, or even some sort of functional limitation, whether it's strength or range of motion, and now you're going to be building upon that, so you're almost strengthening a compensation through the off season here. And if anyone's wondering, I'm looking between 3 cameras because we're live on YouTube over here, Facebook here, and Instagram here. So I'm just trying to keep track and see if we're getting questions on any of them. But I really like doing these live videos because I feel like I can get some things answered and stuff like that. So, and who was it to ask that? Dom 10. We've done some, like I mentioned, we don't do weighted ball stuff here. We've made some posts on that before. Some were controversial, some weren't as controversial to people, but you're welcome to go check those out. We got a few on YouTube, actually, so if you pop over to our YouTube channel, or you're on Instagram, if you scroll way back on Instagram, you'll find some of those. But generally don't find the weighted balls necessary. And I'm always concerned, especially with younger athletes, when you place a weighted implement in their hand and ask them to throw it as hard as they can. And if they have a biomechanical fault, then it may be exacerbated and result in an injury when they have that. So, what else are some good questions we've had recently? Oh yeah, so this is a good one. We recently had somebody that had, and we always have this, but we recently had somebody that has limited pronation. So it totally alters the way that they throw because they can't pronate through their forearm. And when they throw, they actually drag their arm through what we call the open pack position, where they come out here and the elbow is in the more loose pack position where more stress could be applied. So they drag their arm through there in the throw. And it's actually because they don't have the necessary forearm flexibility. So we've been spending time stretching them. And it's really not, it's really, I call it video game thumb. They're always texting, you're always, on a whatever, controller, that type of thing, Xbox, and it results in some supinator tightness over time. And, so they get supinator tightness, you got to stretch them into pronation, and that allows them to get their arm farther out in front of their chest in the throw. But that was an interesting case that we just had where they actually had so little pronation they couldn't get their arm out in front at all, and so we've been hammering that a ton. And it's been very successful. They've gotten a lot better. They've been able to get their arm in more of a stable position that allows them to accelerate the ball. Oh yeah, here's a really interesting one. I was reading a book, or I was checking out a book, and I won't say the name, but it was a stretching book. And the stretching book was created by, hold on one second, Josh Buzenbank. Yes, you can ask questions. Absolutely, drop your questions and I will answer them. But the book was talking about bicep stretches, pronator teres, which is a muscle right here, right there for you YouTube viewers. It does pronation. It's really important in throw. The biceps and then the supinator. And these were people that were professors and college professors. No, they weren't physical therapists, and I don't know their anatomy background, but they were physiology professors, so it was interesting. They actually had done opposites, so their supinator stretch and their bicep stretch and their pronator teres stretch were all opposites, which was mind-boggling to me. I was very surprised. And they had someone stretching their pronator teres, but they were in pronation, which would be a shortened position of the same thing. To stretch the biceps maximally, you want to go into pronation because it does supination. And same with the supinator, it does supination, you want to go into pronation, and they had those flipped, and I couldn't believe it. And when I looked online, no one had actually called them out on it, which I was extremely surprised by. Jake, did you comment anything here? Okay, here we go. Okay, long story, I have a bad supraspinatus that hurts sometimes, and other times it hurts sometimes really bad and sometimes it isn't too bad. Orthopedic surgeon said impingement, rotator cuff, and tendinosis. Lost the comment here. Let's see. This will be multiple lines. Sorry, it's complex. Yeah, drop it down. I'm probably going to go for another 5 or so minutes, so if you drop the question down, I'll absolutely be able to answer it. But just on the topic of tendinitis and supraspinatus tendinitis, something that's overlooked a lot of times and is not actually done is an inferior mobilization, where you mobilize the humeral head down towards the foot or towards the bottom. So downwards can actually add a little clearance of the joint and can be very tight in a lot of people. So joint mobilizations are going to be extremely beneficial. Rotator cuff strengthening, serratus strengthening, teaching you to use the shoulder in a different way. Okay, let's see. When I used to do lateral raises, I would keep my scapula pulled down very tightly and tried to deshrug my traps to focus on medial delts. With golf, I would, let's see, it keeps disappearing on me. With golf, I would protract my shoulder to create a maybe you should just wait till he gets it all laid out for me. But yeah, you gotta always mobilize the joint, and if it's tight, and you always have to improve the strength if it's weak, improve range of motion where it's lacking, and add components that are going to allow the person to incorporate some of that stability in whatever activity they're doing. So depends on the case, but it's always different. Sometimes you have impingement where the shoulder is loose and sloppy and it moves all over the place. Sometimes it's very tight, especially in throwing athletes that have been throwing for a while. Their joint can get chronically tight, like the capsule is tight and restricts range of motion and directs the humeral head in a direction of impingement. So, hello, Chrissy. So I just logged on. Who else we got on here? Oh, a few people I know. Very cool. Let's see what our guy said over here. So let's see. Josh, have you seen I know you've seen an orthopedic surgeon, have you seen an orthopedic specialist, physical therapist? So you're asking regarding downward rotation, where your right side rotated down, so there's less space inside the shoulders. You've seen a PT. I don't know what the PT did, but just was curious. But basically, if you have a scapula that's not like an orthopedic specialist PT, is that a thing? Yes, it is a thing. So there's OMPT, which would signify someone's an orthopedic manual physical therapist. And then there's also OCS, which is orthopedic certified specialist, which is a board certification. That may be easier to find depending on your location. In Michigan here we have a lot of OMPTs, which is a really quality program. And a lot of our therapists actually have been through that. But yes, it's a thing, but basically downward rotation of the scapula probably wouldn't be specifically caused by the levator scap, although it does do some downward rotation. It's not a relatively powerful muscle. Likely what's going on is you're probably weak in your serratus anterior muscle. You're probably fairly weak in your lower traps. You're probably weak in your rotator cuff. And now your scapula sits more tilted forward or more anteriorly tilted, downwardly rotated, and then potentially protracted. And now there's less space for the supraspinatus tendon. You're pinching it inside the joint, and you may not have enough inferior glide or glide down of the humeral head when you move, and so you're impinging it. It's, always multifactorial, and there's a lot of things you're going to have to consider, and a skilled therapist would consider. And the thing I would say is not all therapy is the same. I don't know if they did the right thing or if they didn't. It didn't work, I guess, so we can say that much. But whether therapy is going to work, it works really well when things are done the right way. But things have to be done the right way. So working on serratus strength, infraspinatus. You got to train the supraspinatus. You're going to have to train subscap, teres minor. You're going to have to train serratus anterior, if I didn't say that, lower trapezius. Then you're going to have to train them dynamically so that they can stabilize while you're moving, while you're golfing. There's a lot of things you're going to have to do. But in the end, it's going to come down to mobility of the shoulder, stability of the shoulder, how the scapula sits and how it moves, and then ultimately, if you're allowing it to heal and giving it the necessary rest time, as well as the necessary modalities that are going to assist in healing. And so what I would do is suggest to you, I don't know where you're located, but I would suggest that you see an orthopedic specialist. If you're in Michigan, there's a lot of people that I would know. Outside of that, don't know many people. But that would be my suggestion to you. And do some research. Do some diligent research into people and find out who knows some stuff. And sometimes the best thing to do is ask some knowledgeable people and find out who they trust, and check them out, check out their recommendations. But if anyone has any last minute questions, drop them down. If not, we will see you in the next live stream. So thank you, Josh, for the question there at the end. I don't know if this is not the best time. We didn't get as many questions today, which is fine. We got to answer and talk about some other things as well. 10 physicians, wow. Josh went to 10 physicians. Did they all give you similar answers? I mean, rotator cuff impingement, I mean, you don't know what's going on unless somebody's been inside your shoulder, cut it open, looked at it, you've had surgery or whatever. Even an MRI can't tell you everything, but what I can tell you is a lot of people don't address the necessary things that need to be addressed in terms of the physical therapy aspect. And I myself have been to a lot of physical therapy that was unsuccessful. So I've been there, I've seen it not work, but then it's pretty miraculous when you see it work, when you see it done totally different way. So yeah, I'm sorry I don't know anyone specifically in Indiana off the top of my head. I'm trying to think about people that have been to our course, but my mobility was bad last guy who I currently, and I don't know why they disappear on there. Let's see. My mobility was what I currently see talks about mobility, stability, strength. Yeah, that's great. But in the end, it's how he's doing it. And he might be doing the right thing, I don't know. I've done everything he said and it's gotten much better, but the specific tendon is still a bit sore. How do you work the supraspinatus? Check out some of our videos. You got to be careful. Some of them may cause impingement for you because they're specific to throwing, but most of them should be in ranges that won't necessarily pinch the shoulder. So check out our YouTube video. We got Facebook, everything like that. Yeah, some of them are going to be potentially provocative and put you in a position that might pinch it, but ultimately you're going to have to go through positions that don't necessarily put the joint in the best place, because you're going to have to teach that muscle to contract in ranges besides the empty can, which everyone seems to recommend nowadays. But you want to train the muscle to contract through various ranges, even potentially impinging ranges. So that's what I got for you. Check out some of our videos and you'll see what we do. And if nothing that you're doing is looking like that, then or looking like anything that we're doing, then there's a potential that you're missing something. So but never seen you, don't know what your individual case is. So all right, guys, thank you everybody for logging in, checking us out on YouTube, Facebook, and Instagram. We'll come live again, hopefully in the next few months, maybe next month, and we'll try to do it at an earlier time so get some more engagement on here. try to give people more of a heads up as well. But we'll see you in the next one. All right. See you guys.